of the pool of money that's currently available, the disproportionate share money, to provide for that compensating cost. So the Tennessee hospitals will actually see a decrease in that federal funding over time, whether or not they expand Medicaid. And that will have a serious bottom line impact, particularly on the hospitals that serve the largest number of uninsured folks. So people will continue to get sick. They'll continue to use emergency rooms as often the most expensive, least effective form of care, instead of having a primary health home, health screenings, preventive care. And those hospitals will be compensated less in 2014 than they are today, in 2015 than they are today, and that decrease in funding will continue.
We have a city-funded safety net hospital here, and we also have a lot of community health clinics. People here at Nashville General Hospital, as are these community health centers. Is there anything, I know when this law was written, no one knew that the Supreme Court would make Medicaid expansion primarily a state decision.
Right.
So is there any effort within your agency to look to try to help these entities that really serve the poorest of the poor?
Well, unfortunately, we don't have the ability within our administrative authority to change the legislation, and these formulas are very clearly in the legislation. I think it's unfortunate that we have a number of states where the hospitals that serve the largest number of indigent pay a pretty compelling argument to make inside a state legislature. There is a definite cost of doing nothing, and it's not only borne by the individuals who then have no affordable care, but certainly by the providers who serve those individuals. Doctors don't get paid, hospitals don't get paid, and taxpayers will then be either faced with the choice of coming up with additional taxpayer dollars to keep Nashville General Hospital afloat, or not. And if they don't, you would then lose a hospital that serves a vast number of people throughout the community. Meanwhile, I think it's $6.4 million a day could come into this state to pay those costs, and that offer is available right now.
So many of the states that are not expanding Medicaid are southern states, and I don't know how that formula works, but I would think these were some of the states that might benefit the most. Having said that, I'm also wondering what's happening for the healthcare systems of those states that will have this money to fund their hospital systems to do innovative work.
Well, again, that's this part of the program, like the open enrollment, has just begun. So the states that were ready January 1st are signing up people right now, qualifying them for Medicaid eligibility. But, we're here at a great community health center. And what would happen in a community health center in an expanded Medicaid state is a lot of their patients would now be able to pay for all of their costs, meaning that then the health center would have far more resources to expand care, far more resources to have additional health providers, to pick up additional sites. The CEO here told me that now they do a lot of work with vans going into neighborhoods and into schools, that those services could increase. Hospitals would have the ability to, again, expand services and treat more acute patients, which is what hospitals are well equipped to do, not necessarily dealing with folks who have to come to a hospital for everything from an earache to an acute care.
And Nashville is a city of healthcare innovation. It is not the only city in the United States for healthcare innovation. And, for instance, we're right next to Kentucky. Is it possible that some of this extra money will allow hospitals to innovate and do things that hospitals that do not have these revenue streams will not be able to do?
Oh, I don't think there's any question that the more solvent a hospital is, the more likely the board and the administrators are to look down the road into the future, figure out the newest direction of healthcare. We're seeing hospitals do very creative work in conjunction with community providers, with health homes, trying to, frankly, keep people out of the hospital in the first place, deliver better care, deliver acute care. So, in Kentucky, which has expanded Medicaid and is signing up residents right now, the hospitals who can better pay their bills are going to be able to be more creative, more thoughtful. The ones who can't are constantly worried if they're going to go under, are going to be restricting services, restricting the way that they have to provide care to make sure that they can keep their doors open.
What is your biggest regret with the rollout of Obamacare and the Affordable Care Act?
Well, I certainly wish the technology had worked from day one, because it was a very rocky start. We had 8 weeks of really flawed technology on the website, and unfortunately got branded for a broken website. What is good about that technology path is that starting December 1st, as promised, the website was fixed. People have had a very different experience, and as I said, today we had 1.5 million visitors yesterday. People are able to shop easily, find information easily, and go ahead and get enrolled. But certainly if I could roll back that clock and we had a more functional website October 1st, I think that would have been enormously helpful.
Tom, we can probably do one more question.
That
Sure. What we said is open enrollment ends at midnight, March 31st. But we also want to make sure that people who are trying to enroll, given the volume, given the surge we're seeing, if you're in the system kind of in line, we want to make sure you complete the process. So at midnight on March 31st, we will help you continue on and choose a plan and get enrolled. That's step one. But you have to be in line. It's like voting on election day. A lot of polls close at 7 o'clock. But if you're in line, you vote. You are not left in the dark and in the line. You're able to cast your ballot. So that's step one. But then the law always anticipated special enrollment periods that could occur during the course of the year or could occur just for an individual. So if you have, for instance, a change in circumstance, you were on your spouse's plan and your spouse dies, you're going to need to get your own insurance coverage because suddenly you've lost coverage. If you have a baby in the family and you want to add that baby to the coverage, you don't have to wait till the next enrollment period. So there are a series of criteria that have always been outlined that actually give you the opportunity to come in to the market if you lose your coverage through your work, you lose your job, and you suddenly need coverage. That has always been anticipated, and those special enrollment periods will continue to happen. We're going to have some people who thought they were Medicaid eligible approach to state. They're really likely to be marketplace eligible. We want to make sure that, because states have been a little slow with those lists, we want to make sure that those folks can actually choose a plan and get enrolled. But as I say, those were always outlined in the law.
Thank you.